All right. So first scenario. These are some pictures from a kind of late season summit of Hood a couple years back. This is headed up towards the Hog's Back. And this is a little bit closer. So we're not going to talk through this scenario quite yet, but I'll kind of introduce it as considerations to have through the talk. So basically, you're going standard route up Mount Hood, Hogsback to Pearly Gates. It's kind of late season, a lot of rockfall. You see a group of young climbers in their early 20s. They're surrounding a friend who's lying on the ground. So basically, they were on their way to the summit. They were taking a break when there was a rockfall from a party above, and it struck their friend in the head. They were taking a break, so they all had their helmets off. So he had a couple episodes of syncope and now is sitting confusedly on the ground, also stating that his neck hurts. So I want everyone to take 30 seconds to a minute to think about this scenario. Think about what you would assess first. What do you want to know about the patient, about the scenario? What would be your disposition for this patient? And think about immediate interventions that you might be doing for this patient.
Hey Joe, just to let you know, we are able to see your notes. I don't
You
know
are?
if you had a preference.
Interesting. Let me go to hide presenter view. Um,
That's better.
that's better. All right. There we go. So I'll try and remember everything to talk about. So we don't need to cover this in depth. You guys probably remember more of this than me. Just baseline, we're talking about the brain and the spinal cord, peripheral nervous system, less of our issue today. Quick overview. So the skull, the calvarium, is what protects the brain. It's a rigid, basically, environment with a limited volume, which is both a good thing and a bad thing, as we'll discuss later. And then we have our C-spine, our C1 through C7, which serves as an evolutionary protection for the more fragile spinal cord and also offers some mobility, especially of the head. And then neck anatomy, also very important to consider in a lot of these injuries. Facial trauma, neck trauma, kind of beyond the scope of what we're going to be talking about today. But again, with these kind of high energy mechanisms, rock fall, mountain bike crashes, ski crashes, you get most of the time you're going to have associated neck trauma, facial trauma that you're going to have to be managing at the same time. Brain anatomy, again, we don't need to go too deep into this. Just think about how specific injuries might influence the symptoms you're seeing. And then we'll talk about specifically the anatomy of kind of the coverings of the layers covering the brain, the dura mater, the arachnoid mater, and the pia mater, and how that's going to affect the specific injuries that we see. In some ways, they're going to affect the presentation of the patient. And then same with spinal cord injuries. We'll get less into the specific injuries today as far as like central cord syndrome, anterior cord syndrome, Brown-Séquard, but just remember that the specific tracks running through the spinal cord are going to be influence the injuries that we see there as well. All right, so first step, taking a history. What do you guys think are going to be the main things we want to know? You come across someone, say like this patient who suffered a rockfall event, strike in the head, climbing Mount Hood. What do you guys think are going to be some of the most important things to know? Yep, love it, Eric. Blood thinners, loss of consciousness, current neurodeficits. Anything else? All right. Scene safety. Yes, that is excellent. Yeah, scene safety, very, very important. And when you guys, if you get a chance to go to the MedWar or to the conference and you do scenarios, scene safety, always the first thing you should be considering. You don't want to create a multi-victim situation. So I know we learn old carts in medical school. As far as in a wilderness setting, I really like sample for kind of just a quick and dirty way to get everything you need to know in order to treat the patient in that moment. So signs and symptoms, allergies, medications, especially in the case of head trauma, any anticoagulants, antiplatelets. So thinking like Eliquis, Xarelto, Plavix, aspirin, things that might increase propensity to bleeding. Pertinent history, thinking about the last meal of the patient and thinking about events leading to the injury. You'll want to know, was the patient wearing a helmet? We talked about, was there any loss of consciousness? Have they had decreasing consciousness since the point? We'll talk a little bit about GCS later on and how to assess kind of patient's level of alertness. And just keep in mind that with a lot of these cases, you're going to be thinking about the sample history a little further down the line after you get your initial ABCs in and your primary secondary survey for those of you who've had trauma training before. All right, so physical exam. Another scenario. This is actually the ChatGPT version of a goofy mountain biking accident. I have no idea what's going on here. This guy has his legs fully turned around and seemed to be riding a one-wheeled mountain bike without a front fork or wheel. So I think he was kind of hosed from the start and was going to crash. But your first responder to a mountain biking accident, you've got a patient lying unconscious next to a rock, has a bleeding laceration to their scalp. What are you going to assess first? And you can go ahead, say it out loud, throw it in the chat, whatever works easiest. Sweet. ABCs, exactly, which stand for airway, breathing, circulation, and then disability in the case of head trauma. So airway, look in the mouth, listen, think about is the patient, do you hear any gurgling respirations? Is there any sign of bleeding? Things that could affect the integrity of the airway. Look for breathing. And then think about like poor respiratory effort, agonal respirations as a possible sign of brainstem involvement, that you might have people who have a pontine injury affecting the respiratory centers of the brain, might need more respiratory support. Circulation, think about the neck, mouth, scalp, looking for massive hemorrhage, looking at pulses, upper, lower extremities. And this is something where with these brain injuries, it's very important to think about how you're preventing secondary injury. We'll talk about that a little bit later on. But a lot of times you want to be thinking about immediate life threats, where if you've heard of the March mnemonic, which is massive hemorrhage, airway, respirations, as the initial, and then circulation, and then hypothermia as far as life threats go from like a pre-hospital standpoint. That's another good paradigm for thinking about these injuries because you're going to need adequate circulation to perfuse the brain. Disability, thinking about GCS, glucose, think about hypoglycemia in any altered patient, and thinking about gross motor sensory impairment, not talking about like individual like light touch vibration, you're not getting the tuning fork out. We're talking more about like, does this patient have a gross hemiparesis? Are they not moving anything on the left side of their body? Are they not moving anything below the waist? Exposure, again, this is something when you get more into these wilderness scenarios, you're going to be thinking about your individual situation. Exposure on a day where you're mountain biking, it's 75, 80 degrees out, is going to be a much different prospect than if you're going for a winter ski tour and it's 20 degrees out, 15 degrees out, and you need to take into account hypothermia as well and frequent reassessment of the patient. All right. Who all is familiar with GCS? I'm assuming most people, if we've got EM bound individuals. And if I remember, we did learn this in didactics in med school. So this is kind of a universal way to think about level of alertness in head trauma in the wilderness. We won't go too deep into it, but just think about it has to do with eye opening, verbal response, motor response. The lower the score, the worse, and 3 is the lowest you can get. So minor brain injuries are going to be in that 13 to 15 range, moderate 9 to 12, severe 3 to 8. So head exam. This is where we're starting to get into our secondary survey. So when I'm doing secondary survey in the trauma bay, initial primary is going to be, are they talking? That's how I check airway. Breathing, check for bilateral breath sounds. Circulation, check for radial, dorsalis pedis pulses, stable pelvis. And then I usually start top down when I do my secondary. So for a head exam, you're going to look for scalp lacerations. And keep in mind, these scalp lacerations can bleed like crazy because the head is very vascular. Looking for skull depressions, looking for raccoon eyes or battle signs, which can be a sign of basilar skull fracture. Hemotympanum, plus minus, you may or may not have your otoscope with you when you're in the backcountry. Probably not, but gross hemotympanum you can appreciate. And then CSF, rhinorrhea, otorrhea, clear liquid coming from either the ears or the nose. Always get a good pupillary exam, thinking that a blown pupil or non-reactive pupils could be a sign of some badness happening with the brain, and then getting a good GCS neuroassessment, looking for signs, symptoms, seizure, nausea, vomiting, altered mental status. And by the way, feel free to stop me at any point if you guys have any questions or throw them in the chat. Injury-wise, kind of in broad categories, thinking about skull fractures, scalp lacerations, concussions, TBI, which concussion is on the spectrum of head bleeds, epidural, subdural, subarachnoid, and then diffuse axonal injury. Couple of these you're not really going to be diagnosing in the backcountry, but good to be aware of. Neck exam, like I said, most of these head injuries have a high likelihood of having involvement of the neck or the C-spine. So you're going to be looking for things like swelling, hematomas, tenderness, especially midline tenderness of the cervical spine, step-offs, decreased range of motion, crepitus, vocal changes, and then thinking about like very, very broad neurofunction assessment. Is there numbness, weakness, tingling? Are there vital sign derangements, difficulty breathing? And then thinking about neck trauma injuries, again, not going to get into these as much, but vertebral fractures, spinal cord injuries, primary versus secondary, neurogenic shock, bleeding, swelling. And then when you're going over your exam for the rest of the body, just think about vitals, respiratory cardiac signs, GU, signs of incontinence, obvious hemiparesis, they're not moving one side of the body, or there's a certain level that they've lost motor function below, sensory deficits, looking for a complete skin exam. Is there any bruising, any bleeding, things that you're missing? Rectal tone going to be less in a wilderness setting, but another like adjunct to look for spinal cord dysfunction, altered mental status, baseline GCS, and vital signs that would suggest neurogenic shock. So treatment. We mentioned this before, but the first step of treatment of central nervous system trauma is going to be ABCs, because the main thing that we want to do, a lot of the procedures that we do in the hospital to definitively manage CNS trauma not going to work in the backcountry. Yes, exactly. ABCs and then rapid evacuation. So a lot of what we want to do as providers, medical providers, physicians in the backcountry with our skills is prevent further injury to the brain or to the spinal cord in whatever way possible. So you're going to inspect the airway, look for bleeding, broken teeth. We talked about this. Think about suction, removing foreign bodies, turning the patient on their side if there's active vomiting, if you have concern for airway compromise. The main thing we want to avoid here is basically hypoxia, because hypoxia, any SATs that we're getting below 92 to 93% in the setting of TBI are going to be damaging as far as the outcome goes with the damage to the brain or to the spinal cord. You can do a good jaw thrust in order to open the airway. NPA, nasopharyngeal airway, I would say if there's any suspicion whatsoever for significant facial or intracranial trauma, I would not use an NPA because NPA with skull fractures has the possibility of going the wrong way, which you do not want. It can insert through the cribriform plate and go intracranial, which is very, very bad. So NPAs are going to be contraindicated in the setting of any head trauma. OPAs, remember we only use OPAs in unresponsive patients who do not have an active gag reflex. We're going to establish an airway. If you have oxygen, you can give oxygen, especially at high altitudes. This would be a very good idea because the patient's already going to be a little bit hypoxic just from being at altitude. Control the bleeding as best as you can. Remember, prevent hypotension. But if there's any sign of a depressed skull fracture, if you can feel any bogginess on your scalp exam, do not put direct pressure on that because that can cause further impingement and damage to the brain. If you can start an IV, start fluids, and then don't miss other life threats, especially hemorrhage. One thing I would definitely note when you're dealing with these injuries, especially someone who's decked out in like their outer layers, their waterproof layers, if they have a bad head injury, that can be very distracting, or bad facial injuries, but that can run the risk of missing like a bad intrathoracic, intra-abdominal, or pelvic injury. That could also cause hypotension, could cause the patient to crash. So don't forget about everything else in your assessment. Oxygen, get good vitals on the patient, and then get them glucose. So anyone seen one of these before? Cool. I've got a couple yeses. So this is called an iGel. LMA is very similar thing. I know we all kind of hear those stories about people doing like their heroic intubation in the backcountry. Yep, exactly. So iGels and LMAs are kind of designed to be pre-hospital adjuncts for airway that are very easy to insert. You don't need significant training for these. You basically open the airway, you've got an unresponsive patient, you insert them, and then you have a more definitive airway than just bagging a patient. If you have access to these, they're a good consideration if you have a patient with a rapidly declining GCS as far as protecting the airway goes. As far as head trauma goes for treatment, just some things to know, think about, is this a closed versus an open injury? And then was the mechanism penetrating versus blunt trauma? Almost 99% of what we're going to be dealing with in the backcountry is going to be blunt trauma, rocks, falls, those sorts of things. External head injuries can be a sign of internal head injuries. Always control the bleeding of the external. Think about skull fractures, signs of basilar fractures. Think about your signs and symptoms of brain herniation, which we'll talk about a little bit later, but There are some things you should be aware of that are signs of like very impending bad prognosis. Primary versus secondary brain injury, avoid hypoxia, hypotension, systolic blood pressure less than 90. You want to have a goal of your MAPS in like the 70s to the 80s for a patient. And then low oxygen, high CO2, worsen cerebral edema. Keep the airway open, give oxygen if you have it. And then if you're really worried about a bad head injury and you're waiting for the helicopter, then you can raise the head of the patient greater than 30 degrees. If they're on like a vacuum splint or a backboard, just prop it up a little bit to decrease the intracranial pressure, decrease the risk of herniation. And I think, as Eric put in the chat earlier, number one thing, as soon as you have suspicion for bad intracranial trauma, get them evacuated. This is like a definite helicopter situation. You want to activate your SOS, get them out of there ASAP, get them to a trauma center. We won't get too much into the nitty gritty of cerebral perfusion pressure, but just know it's a mix of your blood pressure and your intracranial pressure. And this is why keeping your MAPS high and keeping your intracranial pressure low is good, because you're going to keep perfusion to the brain. And then we also want to keep our ICPs low to prevent herniation of the brain. Measuring these, not something you're going to do in the backcountry, but good to just have a conceptual knowledge of this. More like med school nerdiness, the Monroe-Kelly doctrine. You guys may or may not remember this. No math for this, but just remember the skull is a set amount of space. Anytime we have new intracranial pathology, tumor, hemorrhage, that's competing with everything else in the brain for space. So if you have a bad head injury, there's an intracranial bleed, then you're going to be competing with the brain, with the CSF, with the venous system for space in the brain. And as the mass gets larger, as the bleeding gets more, we are going to lose our ability to auto-regulate with draining CSF and venous blood. So we're going to get at a point exponential increases in intracranial pressure, which will cause a crashing patient, which is very bad. So thinking about our injuries, skull fractures, not too much we're going to do in the backcountry for this, but you can recognize them. Scalp lacerations, the finer points of repairing a scalp laceration kind of beyond the scope of this. For those of you going into emergency medicine, just be aware that a scalp laceration like this can affect not only the skin and the dermal layers, but also affect the aponeurosis overlying the skull. And that can lead to issues with muscle function if that's not repaired adequately. So always be on the lookout for that. And this is a good example of just how much like these stinking head injuries can bleed. You can get definitely hypotension, and even in cases of bad bleeds, like exsanguination from these head bleeds if they're not controlled. So think about applying pressure, think about applying quick clot, what you can do to stop the bleeding in these cases. Concussion is going to be a more minor injury, not as life-threatening. You're going to have potentially a transient alteration in the patient's level of consciousness. You're going to have some longer-term minor neurologic deficits, things like headaches with reading, forgetfulness. You can see stars with this, going to be less severe than some of the more severe pathologies we're talking about. TBI, as we talked about, kind of graded on a scale of the GCS level that you're looking at. When we're going below GCS 13, that's where we're going to be in our moderate to severe TBIs. Head bleeds, we'll talk about a little more on future slides. Cerebral contusion, basically an injury to the brain from blunt trauma, can cause increased pressure. And then diffuse axonal injury, not really pertinent for this talk, just know that's a very bad injury, very bad prognosis. So our brain anatomy recap, without giving too much PTSD from med school, we've got our dura mater, our arachnoid matter, and then our pia mater, and those are going to basically affect the specific morphology and the time course of the different injuries we're going to see. First thing, epidural. This is kind of a weird, maybe like European way of saying it, extradural, but More you're going to hear epidural hematoma, which is going to look like this on imaging. So this is basically side blow to the head, affects the middle meningeal artery, is going to cause this classic like lenticular lens-shaped bleeding within the head. And this is where we get that classic like lucid period with a rapid decline because especially in younger patients who have larger brains, less space within their skull, as these rapidly accumulate from arterial bleeding, it can cause rapid increases in ICP herniation. And these also are going to be limited by the sutures when you see them on imaging. And that's why they kind of have this limited nature to them because it's happening above the dura mater where the dura mater attaches to the skull at suture points. This is our classic subdural. So we see it's less lens-shaped. It's going to be more of a diffuse bleeding pattern, but can be just as severe. We see here very severe midline shift, not a good sign on imaging. We see this a lot in older patients and can happen in younger patients, especially with high energy mechanism. But especially as we get older, the brain shrinks a little bit. There's more force imparted on the arteries, veins in between the dura mater and the arachnoid mater that can lead to more easy subdural hematoma. And then finally, this is our traumatic subarachnoid. In this image, we're actually seeing kind of like a coup contra coup mechanism where you can see there's some soft tissue injury on the left side of the head, causing this more like diffuse bleeding pattern within the brain that's going to be tracking with the specific gyri of the brain. So this, again, I know we kind of think about this classically as like a spontaneous mechanism, the aneurysm, but this can also be seen in traumatic injury. And then I don't have a picture of it, but also think about intraparenchymal hemorrhage, which can be an injury within the brain itself. All right, does anyone know Cushing's triad off the top of their head? I promise we'll get to the fun scenarios in a little bit. All right. So Cushing's triad, this is like a bad sign. I've seen this once in a patient with a head bleed who had a, sorry, that's my roommate's dog howling in the background, but basically this is a very bad sign of impending herniation for a patient. So this is one where if you can, you want to get them out as soon as possible. You want to pull out all the stops, but candidly, at this point, it might be a little too late for that patient if you're starting to see this. Basically, it's dysregulation of a lot of the autonomic function within the body, increased blood pressure. So you're going to see significant hypertension. You're going to see heart rate dropping down to 30s, 40s, and you're going to see decreased respiration with agonal breathing. Flexor and extensor posturing, if you guys remember, this was on the GCS scale, both bad signs. And then as far as decision making for these patients, so this is was an Auerbach's Wilderness Med textbook, and I think it's a pretty reasonable way of approaching decision making for these patients. So you've got a patient who's GCS 15 or transiently 14, now back to baseline with no loss of consciousness. You can consider continuing on your trip. Say you're on like a backpacking trip, or monitoring the patient to make sure they're okay. If you have GCS 14 to 15 with loss of consciousness, vomiting, any kind of altered mental status, this is where we're going to start getting into that evacuation territory. You can think of more of an urgent course than an emergent course, but that person's going to need assessment at a center with imaging capabilities. And then once we're getting into that GCS 13 or less, moderate to severe TBI, that's where we're going to get emergent evacuation. You're going to do your best to avoid secondary injury and think about adjuncts, protecting the airway, oxygen, keeping the head of the patient up, depending on the situation. So given that we're all kind of wilderness enthusiasts here and outdoor enthusiasts, I just wanted to talk briefly about like MIPS and wave cell helmets. I'm not sure how many of you guys have heard of these. I recently switched to one for both my cycling and for rock climbing, and probably going to switch to one for skiing this upcoming season. But basically, this is a technology based upon like redirection of rotational energy. It's thought to like decrease the incidence of concussion, subdural hematomas, diffuse axonal injury, things that are caused more by oblique rather than straight on hits to the head. Intended for use in like snow sports, cycling, climbing, things we're all interested in. And I saw very few studies, but some showed like decreased rotational acceleration, decreased probability of concussion. I didn't see much retrospective population data like really showing what outcomes look like with this. Most of it is just like industry testing at this point. But from my standpoint, it seems like a pretty good idea. It's not too much more expensive, and at least based on the studies that have been done, shows some decreased force with these injuries. So that's what I've got for head trauma. We're going to go to spinal cord real quick, but before I move on, any questions about head trauma or what we covered? Nope. Cool. All right. So spinal cord injury, again, think about penetrating versus blunt trauma. We'll talk a little bit about cervical collars and the current like thoughts regarding those in the pre-hospital setting. The WMS just released new guidelines for like wilderness pre-hospital C-collar or C-spine immobilization this past year that are pretty interesting. Spinal cord injury, kind of like head trauma, is higher probability in older adults. Avoiding hypoxemia, hypoglycemia, hypothermia, just like a TBI, you want to decrease secondary injury to the spinal cord. The main thing about these injuries, if you've got a helmet on and there's any concern for access to the airway, patients in cardiac arrest, you want to stabilize the head and get that helmet off, stabilize the C-spine, get the helmet off. And covering the way to do that is kind of beyond the scope of this talk today, but definitely if you participate in the conference, I know we went over that this year. Consider padding under the shoulders in PEDS patients. Lower cervical spine injury is more common than upper, and then consider epidural hematomas as a possible mechanism with trauma, especially in patients with blood thinners who might bleed spontaneously. They can develop these hematomas overlying the spinal cord from trauma. So C-spine immobilization. Sorry for the wall of text. I think it's super important to cover. So mainly the thing that you want to, the main goal is spinal cord protection. This can mean different things depending on the situation. So this is all going to be very context dependent. But the main thing you want to do is, without forcing it, restore and maintain natural alignment of the C-spine. Jaw thrust for airway is always going to be better than head tilt chin lift. If you have suspicion for C-spine, you should not be tilting the head. KED extrication devices, if you want to Google that after this talk, are a pre-hospital device that can be very helpful for extricating from difficult situations. We'll talk about the trap squeeze technique. If you learn anything, learn that for stabilizing the C-spine. Lifting and sliding a patient onto a vacuum splint rather than doing the log roll onto the side has been shown to be superior. I believe C-collars still have a place. I know there are a lot of pre-hospital systems that are going away from this, but if you have high suspicion for a C-spine injury and it's the correct clinical context without high suspicion for an airway issue, or that you might need access to the front of the neck, I think there's still a very good place for C-collars in the correct situation. I'm seeing a big shift to vacuum mattresses over backboards, which is very good. Vacuum mattresses have been shown to have very good C-spine protection. Canadian Nexus, we won't get too much into those, but just know if you're going on to like your EM audition rotations, those are two very good decision tools to look smart in front of the residents and the attendings. And then think about like the context of the injury, the extrication. Are you skiing? Are you rafting? Are you climbing? And this person is going to require like a litter carry to get out of the climbing situation. Are you mountaineering on the side of Rainier or Hood or somewhere like that? And that's all going to affect your decision of what C-spine immobilization and protection you're going to use. So if you're going to take anything from this talk, when I learned C-spine stabilization in med school, I learned to grab at the head, which is fully inadequate for stabilizing C-spine. You want to do the trap squeeze like this is showing in this picture. You want to get your hands onto the shoulders and use your arms to lock in manual inline stabilization, going all the way from the shoulders to the ears. So just good to be aware, Nexus and Canadian C-spine have both been shown to be good rule outs for C-spine injury, especially in a wilderness setting. These mirror a lot of what you're going to see for like trauma rule outs or for like EMS rule outs in a more like urban setting. But Nexus, if there's no focal neurologic deficit, no midline C-spine tenderness, no altered level of consciousness, no intoxication, no distracting injury, at that point you can clear the C-spine. And the one addition I would make that I really like from Canadian C-spine, which is a little more stringent in its guidelines. You can see the rule out criteria are going to be older patients, people with paresthesias, or a dangerous mechanism, which is going to be a fall greater than 3 feet, which is basically any like mechanism in an outdoors activity. But the one thing they add is once you do the initial like assessment of the patient, assessing for that ability to rotate the neck 45 degrees to the left, to the right. Again, as long as they're not altered, they have no midline tenderness, and there's no distracting injury as the final step to clearing that C-spine. These are just some different fractures. We're getting kind of on in time, so we can skip over these. All right, so going back to our initial scenario. So let's talk through this. So we've got a group of climbers in their 20s, taking a break. You come up, one of them got hit in the head, lost consciousness. We'll say the scene's safe. What's going to be our next step here? You can go ahead, throw it in the chat when you're assessing this patient. What is going to be the first thing that you're doing? Sweet. Awesome, Elise. ABCs. So we'll say patients protecting their airway. We've got good bilateral breath sounds. We have good circulation. So patient passed out, right? I think Eric mentioned this before, but what are we going to be doing immediately just with the mechanism and knowing that this patient passed out? They're still a little bit confused on the mountainside. What are we going to be calling for right off the bat? Yep. Yeah, exactly. So you're going to be popping that Garmin inReach. You're going to be hitting your SOS. You're going to be getting in touch with search and rescue and letting them know the severity of the situation, making sure that we're getting a helicopter out as soon as possible to assess the patient or to pick up the patient, get them to a trauma center for assessment. Think about the other things we're going to be doing: oxygen if we have it, checking for other injuries with our secondary survey, making sure this patient was complaining of neck pain. So we want to get some kind of C-spine stabilization on them. You can even use a SAM splint if you have it. And then, yeah, we'll be getting this patient out as soon as possible. Thinking about if we have suspicion for a head injury, we're going to be keeping the head of the patient up. We're going to be keeping a close eye on them. All right. So we have one more scenario. This final scenario is going to be one that actually happened at Yosemite National Park, so we won't be recording it for YouTube. There's no patient information, but just want to keep that to the group. But before we go on, any questions about anything from the talk?
Yeah, Joe, I had a quick question. So, anecdotally, especially if you have a slightly altered patient, I have found that C-collars will often just make people absolutely thrash.
Mm-hmm.
And in those situations, like, kind of bridging the gap between like hospital, pre-hospital, and wilderness med, right? Like,
Yep.
where do you feel like we should kind of fall with like these patients who, um, are altered and are not tolerating C-collars? Like, because I can definitely see an argument for like this person's absolutely hammered. They can't feel their neck anyways. Like, we need to get
Mm-hmm.
a C-collar on. But then there's also the like, well, this person's not that drunk, like, or they're not that injured, that they're that altered. And this is just making things worse. Like, do you think it's reasonable to like remove C-collars in a lot of situations, or what's your understanding of kind of the guidelines on that?
Yeah, that's a really good question, Eric. And you're kind of getting into the dark arts, into the nitty-gritty of where the debate lies, right? Is so like in a situation like that, ideally, hopefully, you would have a vacuum splint, and you can use that. Vacuum splints have been shown to have good C-spine motion reduction, spinal motion restriction in the pre-hospital setting. The main concern, if you have like a severely altered patient who can't feel pain, is that most people in studies have been shown if they're feeling pain and they're able to kind of like self-modulate, are going to be protecting their C-spine on their own. And you guys know it. I've seen it. You see them in the hospital, someone whose neck really hurts after a car crash, and they're holding completely still, and they're doing a good job of spinal motion restriction. So I think it'd be kind of a case. So candidly, a lot of it's going to be depending on like your local protocols. If like EMS, search and rescue are protocolized to put a C-collar on that patient, you're probably going to be doing it. If you've got someone where you have lower clinical suspicion for a neck, for a C-spine fracture, no step-offs, no deformities, no focal neurodeficits that you can appreciate, that would be a situation where if they're not tolerating the C-collar, I could see, or if they're in like a position, say like a climbing accident, a rafting accident where it's not safe to get it on them, you could choose to defer and keep a very close eye on that patient until a better point. But if you have any clinical suspicion at all, external injury or the mechanism for it, then in that case, you're probably better safe than sorry getting the C-collar, at least some kind of spinal motion restriction on board to make sure that that patient isn't further injuring themselves.
That
Does that
makes
make sense?
Yeah, definitely. And I really like the idea of the vacuum splint too. Like, I've
Yeah.
seen them switch out from like a hard collar to a soft collar because they're slightly better tolerated, but I really
Mhm.
like the vacuum splint idea.
Yeah, and the other thing is in the hospital, we have these really nice Aspen collars that we don't have in the pre-hospital. The Philadelphias are definitely not as nice as the Aspen, which are those like gray molded ones that are much more comfy for patients. Any other questions?